Let me welcome you to the 6th International Workshop on Interventional Pediatric Cardiology. And the objective is to show the state-of-the-art and future perspectives in what we are able to do now with the catheter interventional procedure for treatment of a variety of congenital heart defects, starting from fetal life to adulthood. We will have, of course, lectures, round tables, discussion, live cases with the audio-video transmission with the cath labs located here in San Donato in Milan and other centers, Massa, Napoli, Genova, Budapest and Berlin. Let me thank the prestigious international faculty.
Il neonato può avere fino al 40% dei suoi fluidi nello spazio extracellulare, mentre l'adulto sta intorno al 20%. Questa diminuzione poi della total body water è particolarmente rapida nei primi giorni di vita, ok? E continua velocemente nei primi 6 mesi di vita e dicono che si stabilizza in età scolare.
The goal in performing hybrid procedures is, of course, to reduce morbidity and mortality, as well as the cumulative impact of interventions. The goal is also to improve the quality of life and to deliver more efficient and cost-effective care, and to develop new management strategies as well.
And I'm going to talk about fetal interventions for left heart obstructive lesions, and I put the term up there, fetal and maternal interventions, because we must not forget that there are 2 patients involved in this procedure, the fetus and the mother.
Over the last 5 years would support at least the concept of a hybrid approach as a viable alternative in these patients, that the outcomes with the combined stage 1 and comprehensive stage 2 are similar for hybrid and the Norwood approach in terms of survival and reintervention rates and length of stay and charges.
Okay, first of all, angiography in the ascending aorta. Next one. We entered the coronary fistula from the left coronary artery, and we entered the tighter part of the fistula by using a Terumo glide wire. The wire was catched in the pulmonary artery in order to obtain create an arteriovenous circuit. Here again another angio with a multi-track catheter. Finally, we positioned the net French AGA sheet from the venous side in the fistula, and from the arterial side you can see an angiography made with a pigtail. Another angio, please. Okay.
You can see the device appearing. Actually, you can't see the aortic valve very well because it's more anterior.
Well, there is a long sheet across the defect. You see the left ventricular angiogram with this, I would say, high muscular VSD for angiographic point of view, but probably there is an additional hole on top of the major defect. Then an exchange wire is advanced up to pulmonary artery to the LPA. Then it is snared from the venous side, from the catheter coming from the femoral vein, an arteriovenous circuit established in that way. It was also easy to advance an 8 French long sheath over the wire up to the aorta. Then we will pull back everything, entering the left ventricle. Fluoro and echo pictures, please. The left disc is deployed. We are approaching the septum now. Okay. Let's do another quick test. Okay, inject. Okay. I'm unscrewing the device. Okay, the device is released. The size, I think, is okay. So we agreed about to use an 8mm device, and I think it is the right size. The position looks perfect to me. The echo pictures large. Yeah, there is some flow across the defect, not surprisingly. We are expecting that. But I'm quite happy about the appearance of the position of the device on the last angiogram we performed.
I think the successful implant of any intravascular stents depends on first the proper equipment and then the proper use of that equipment and the attention to the details all along the way. As soon as you start shortcutting, you're going to shortcut yourself into problems. So double-checking the technique, the equipment at each step, and following through. As you all know, once the balloon starts going up, there's no turning back, and that's some extra work.
It was a nice and interesting setup of data. I will send an email to all the investigators to send their own data and update. I think nowadays in this European registry we could collect more than 600 patients. If we have a long-term follow-up, at least or 3 or 4 years, this is a fantastic and very useful amount of information.
In conclusion, I will leave you the message did by Gary Webb, Michael Gazzoulis about this group of patients that suggest why it is also better to close transcutaneously this defect, because patients who undergo device closure have a much shorter recovery than those who require surgery, and thus enjoy the benefit of improved hemodynamics and increased systemic cardiac output much earlier.
Defining difficult PFO, it's all a matter of seeing what you're doing and applying which device you're going to use for successfully closing that patent foramen ovale.
As Lee mentioned, pulmonary insufficiency may result in progressive right ventricle dilatation and failure, arrhythmias, and therefore sudden death. Therefore, most of us, we do believe that resurrection of the pulmonic valve at an appropriate age may, and underline may restore RV function and may result in improved symptoms. The big question that we are struggling with now is timing. When do you think that if you interfere and resurrect the pulmonic valve, the RV function will be restored? And that's a debate that's ongoing, and hopefully soon we will find some answers.
Balloon dilate the coarctation, and the other option is to put a stent in. And
regular bare metal stent, or you're going to use a cover stent?
Because that's a 9 French tubing. Just covering the stent up completely, and then we're ready to implant or push through the diaphragm off the Mullins sheath. So I tend to put the tubing through, and I think that looks in a pretty decent position, don't you?
Yes.
Okay. So we'll do just one more angio there. Okay, that angiographically that looks all right, doesn't it, to you?
It looks very good.
So what we'll do is just advance an end-hole catheter and measure pressures above and below. There's a good distance between the left subclavian and the aorta coarctation area, and therefore I don't think it matters much whether we put the guide wire in the left subclavian or in the ascending aorta.
Lava.
Yeah, if there was a short distance and there was a curve on the arch, then it makes sense to go around the aortic arch.
So you're going to take at the last angiogram?
Okay, we're ready for the angio.
Yeah, congratulations. That's a very good job.
So what you should take home with this is balloon angioplasty works very well in adult coarctation. Complications during catheter treatment of coarctation occur despite stents, actually are frequently caused by stents. Stenting makes the procedure more interesting for the interventionalist, but not for the patient.
On the basis of available data, stenting can be proposed as a primary treatment in adolescents and adults with aortic arch obstruction. And as you can see in my place, the spectrum of the different modalities for treatment of coarctation is like this. So I'm not just a fan of stents. I think that we have patients that we should consider stents as a procedure of the first choice.
Cover stents have been recently introduced in clinical practice, and during these days you have seen how they look like. In our experience, San Donato, between January 2000 and December 2006, 110 patients were treated with a median age of 15 years, with a range between 6 and 66 years.
I think that everybody had a satisfaction. In the majority of the patients, everything went well.
I hope that you will join all of us in 2 years, again here in Milan with Mario. I would like all of you to give a big hand of applause to Mario and his team for putting this spectacular meeting on.